So this lecture is a supplement to the nervous system lecture looking at the different components, but this is kind of tying in the nervous and muscular system and really emphasizing the differential between the motor and the sensory input, and then introducing a concept of dermatomes and myotomes. So when we look at the nervous system, we have the central nervous system here, and then we have the peripheral nervous system. And regardless of the nervous system, we tend to depict the nerves as signaling, as electrical signal, and it is a current. It kind of does create a electrical current, and the signaling is basically from the matrix, right? It's a series of stop-go signals, and on off 0 1 or binary code. And basically, if you were to try to tap into the communication of the central nervous system, this is what you would be seeing: stop go, or 0 1 0 1. And basically everything that we can do as humans is based on signaling like this, like on off, go go go, and it's all encoded that way. And it's all being conducted via these neurons. And this slide shows that there's a distinct flow from the head of the neuron down to the dendrite to the tail. And that flow of information is one direction. And so we have dedicated nerves that are going from the nervous system to the muscular. So in this case, we have motor. So here's a motor unit, and the nerve is innervating the muscle. And really, just to be specific, the nerve is innervating fibers of the muscle. And you have different types. You have multiple motor neurons coming down, and we talked about motor unit recruitment and how the body can selectively pick each of the motor units and use them in certain order in certain way. But in terms of the functionality, the muscle fiber is either on or it's off. So this signal coming down is either on or off. This is on or off, or on and off, and so it can modulate the output based on how it recruits those muscle fibers. So not only do we have motor aspects, so information coming from the brain down the spinal cord, exiting out of the anterior or ventral horn to the muscle, you also have a feedback coming back to the nervous system from the environment based on receptors. And these can be your five senses, touch, or kinesthetic proprioceptive type components. So when we look at the slide that we talked about before, the divisions of the nervous system, you have the peripheral nervous system and the central nervous system. And within that, you have sensory input, afferent information, and you have motor, efferent. And the nervous system lecture goes more into this, but we're going to talk more specifically about these two aspects. And recall, regardless if it's input or output, it's stop-go signals as the primary means of communication. And the way to look at these nerves is like a highway. Right, so you have a direct flow of information, in this case traffic, but in the brain it's information, and then the information is 0 and 1s. And you have a dedicated route of sensory input and a dedicated route of motor output, and those cannot cross over, right? You have a distinct component. So when we look at the central nervous, peripheral nervous system, you have exchanges of information, of sensory information coming from the PNS to the CNS, and you have output coming from the CNS through the peripheral to hopefully get to the muscular system. So you have that sensory aspect coming in, you have that motor output coming out, and when we start looking at how we clinically start to observe this, or how we start to appreciate this, are through the sensory aspect of dermatomes, certain parts of the body that are associated with certain parts of the nervous system, and myotomes, certain outputs, motor muscle function based on certain levels. And I keep on saying certain levels, and if you recall, the spinal cord, or at least the cervical spine, and from a bony perspective, had different divisions. So you had your cervical, your thoracic, your lumbar, and your sacral. In each of those aspects, you have nerve roots that are exiting and becoming the spinal nerves. And so you have a C1, C2, C3, and you do have a C8, right, an extra cervical nerve root. And these levels all are distinct. So you have C1 coming out, and you have a sensory motor output coming out, and that controls and receives feedback. It's a particular highway, and you have a highway here and a highway there, and then you have the main thoroughfare through the spinal cord, through the central nervous system. If we look at the spinal cord itself, you can see here's a cross section. Here's a spinal cord here. You can see the spinal nerves coming out. Each of these are at different levels, so we're looking at one particular spinal level. You have that sensory information that comes in from the environment into the spinal cord and then up the tracks here. These are special highways within the spinal cord itself. And then you have information processing in the brain, and that information comes back down and it's sending motor output here, and you can see that it's a shared spinal route, just with a dedicated lane for sensory and a dedicated lane for motor. So each spinal level is associated with a particular motor output and a particular sensory input. And so this is where the concept of dermatomes and myotomes come from. So when we look here, you can see that the C2 nerve root is responsible for getting sensory information from around the collar, and it's also involved in, say, cervical flexion and lateral flexion. We look at L2, the hip flexors, and you can see it's kind of in that area for the hip flexors, and it's also the sensory information that's there. So these are general maps that are used clinically to kind of appreciate if, let's say, there is some weird tingling on the skin or numbness in this particular area. Let's say someone had numbness around the knee, that you can suspect that maybe something might be going on around here at the spinal level that might be implementing that. Or let's say someone has weakness in hip extension on the left side but not on the right side, you can start to expect like L5S1 as an area of spinal concern, particularly if you start to see things like bilaterally, if you see both sides, like just hip extension, some issue there. So this is how it's used clinically. In your book you have this image, and this is a good image. It kind of shows overlaps between the nerves, so you don't really have just C5 controlling elbow flexion, but that C5 through 6 and 7, there's some overlap there, and everyone's different. So just because this image shows, let's say, the navel, the belly button right at T10, that might be a little higher for someone and maybe a little lower. So you're not very specific, zeroed in, but you get pretty close, right? You'll be within one spinal level. So this is dermatomes, and the way this is working is that this sensory area of the skin is responsible by this spinal level. And you can see that in the torso it's nice and these parallel lines, easily distributed. But then when you get through the neck and arms, you can see it kind of wraps around. And we'll talk about this weird presentation, the way the nerves kind of distribute through. But that was the dermatomes. The myotomes have a little bit different aspect. Instead of having these region maps, like this looks like a topographical map for a human, you have these particular areas that are under control of those particular nerves. So we'll look at the myotomes and we'll go back and finish the discussion on the dermatomes. This list here has the strongest association, so like studies that have showed that people clinically showing weakness in these particular areas end up getting MRI imaging, and yes, lo and behold, there's some impingement on that spinal nerve root or facet joint or lumbar disc herniation. For the exams and for moving forward, when you take an anatomy class, you're going to have to know specifically like which nerve, like the musculocutaneous nerve that comes out of these 3 or 4 nerve roots from the brachial plexus, this controls here. And you'll have to kind of know that clinically. For this functional anatomy class, we're more focused on the musculoskeletal components. The level of expectation would be just your general region. So if you're talking about, let's say, shoulder flexors or abductors, you're thinking about the C5 area. If you're thinking down by the hand, you're thinking C6, C7, C8, and even T1. When you start to get through the torso, that's pretty even. When you have like trunk flexion is going to be all the thoracic aspects. So we skip through that. Hip flexion, knee flexion, and so forth down the line. So just knowing that general association with those general levels, that's what you should know for this particular class, because we're going to focus more on the muscles. Now we'll move back to the dermatomes, and you can see that the dermatomes have these horizons. You can see that it starts to wrap around and come down. So the best way of looking at dermatomes and kind of keeping appreciative of this is thinking of someone bent in half or touching their toes. And you can see like the sacral, the butt here, back of the legs, bottom of the feet, and then it kind of has that pattern. So this is the better way of looking at it, not from the anatomical position, but actually getting out of anatomical position and looking at it from this perspective. Sometimes these images are depicted with people sitting, which makes it even more sense for like the foot and leg, the heel, the back of the heel is S1, front of the leg is L5, and some of the anatomical models, I couldn't find a good image of it, but this is the dermatome map that's used like this, so it's the legs and arms out to the side, and that's the best way of depicting these dermatomes because they are all parallel or horizontal with the spinal level. Sometimes you'll see these depicted like this with the arm out and the legs to the side, but again, as long as you're kind of associating that the spinal level has both a sensory and a motor output, and that's the basis of the dermatomes and myotomes. So just setting the stage for when we actually start looking at the muscles, to like when we look at the upper extremity, that we're probably going to be dealing with the top cervical vertebrae and maybe T1, but no way are we going to be dealing with the lower extremities or the lumbar or lower thoracic spine when we're talking about upper extremity and vice versa. And a quick introduction to dermatomes and myotomes, and kind of looking at how we clinically use the motor and sensory input from the nervous system.